Hi everyone, our subject today is hypotonia and weakness in infant. Introduction. Hypotonia is an impairment of ability to sustain postural control and movement against gravity. Floppy infant exhibit poor control of movement, delayed motor skills, and hypotonic motor movement pattern. Weak infant always have hypotonia, but it may exist without weakness. Phasic tone is a rapid contraction in response to a high-intensity stretch. Postural tone is the prolonged contraction of anti-gravity muscle in response to the low-intensity stretch of gravity. The maintenance of normal tone requires intact central and peripheral nervous system. Infants who show delay in all aspects of development and have other evidence of brain dysfunction like abnormal eye movement or seizure, dysmorphic feature, or exaggerated deep tendon reflexes probably have central causes of hypotonia. They usually have markedly diminished spontaneous movement. An alert and active infant who has significant motor weakness and absence deep tendon reflex is most likely to have peripheral causes of hypotonia involving anterior horn cell, nerve, neuromuscular junction, or muscle. The persistence of primitive reflex like Moro reflex, tonic neck reflex, in the absence of spontaneous movement is suggestive of cerebral disorder. Silent point in history taking, consanguinity marriage, reduced fetal movement, feeding difficulty in neonatal period, family history of sibling death, similar illness, static versus progressive, choking episode, increasing respiratory efforts. Point favoring central hypotonia, global developmental delay, dysmorphic feature, normal or brisk tender reflexes, increased tone of neck extensor, other organ involvement. Examination of a hypotonic infant, posture, lack of or reduced spontaneous movement, full abduction of leg, arms either extended at the sides of the body or flexed at elbow with the hand beside the head. Skeletal, fixed deformity like clubfoot, arthrogryposis, pectus excavatum, hyperlaxity of the skin and joints. Horizontal suspension, the infant is suspended in prone position with the examiner's palm underneath the chest. The hands and leg of the hypotonic infant lies limply forming an inverted U-shaped posture. Vertical suspension, an infant who has hypotonia slips through at the shoulder when the examiner grasps him or her under the arm in upright position. Traction response, head lag or hyperextension is evident when the infant is pulled out by the arms from the supine to sitting position. Scarf sign, in hypotonic infant, on grasping the infant's hand and pulling it across the chest, the elbow can easily be brought well beyond the midline. Wheelbarrow in prone position when the child is raised holding his leg in the air, whether he or she can support his weight on hand with test. A complete neurological examination should be performed. After performing history and physical examination, how to approach to child with hypotonia, infant with hypotonia after performing history and examination. Is it generalized hypotonia or weakness, which is central? Is there dysmorphic feature present? If it is yes, differential diagnosis, Prader-Willi syndrome, Down syndrome, Joubert syndrome, MECP2 duplication, and other chromosomal syndrome. If there is no dysmorphic feature in central hypotonia, is there maternal weakness present? If it is yes, patient and mother need EMG, consider anti-acetylcholine antibody, testing with short-acting cholinesterase inhibitor, genetic test for congenital myotonic dystrophy. Differential diagnosis, myasthenia gravis, congenital myotonic dystrophy. If the mother has no weakness, consider MRI of head with or without spine, TSH, creatine kinase, EMG, Clostridium botulinum toxin, muscle biopsy with or without additional metabolic and or genetic workup. Differential diagnosis, systemic disorder, illness like sepsis, hypothyroidism, brain malformation, hypoxic ischemic encephalopathy, myelopathy, cerebral palsy, other static encephalopathy, post-congenital infection, post-trauma, post-intracranial hemorrhage, spinal muscular atrophy, botulism, congenital myotonic dystrophy, metabolic disorder, connective tissue disorder, myopathy, congenital metabolic, myasthenia gravis, juvenile, congenital, transient neonatal, leukodystrophy, paroxysmal disorder, pyruvate carboxylase deficiency, benign congenital hypotonia, congenital hypomyelinating neuropathy. If the infant has peripheral hypotonia or weakness at the distinct motor sensory level or asymmetric unilateral hypotonia or weakness, perform spine with or without head MRI or CT, differential diagnosis, spinal cord disorder, meningomyelocele, cord transection, myelodysplasia, tumor, CNS lesion, intracranial lesion, anatomic malformation, stroke. Hypotonia and weakness are almost universal finding in infants with Down syndrome. The strength improve, but the hypotonia persists as they grow older. Some reference say hypotonia without weakness may suggest a syndromic diagnosis like Down or Prader-Willi. Infant with Prader-Willi syndrome present with marked hypotonia, poor suck, and feeding difficulty in early infancy. Characteristic phenotypic feature like narrow bifrontal diameter, almond-shaped palpebra, short stature, small hand and feet, hypogonadism, pathologic food-seeking behavior, and obesity become evident later in childhood. Weakness improve in these children, although the hypotonia persists. Classic Joubert syndrome is characterized by distinct cerebellar and brainstem malformation, hypotonia, and developmental delay. Often there is a presence of oculomotor apraxia and episodic tachypnea. Cognitive disability are variable. MECP2 duplication is an X-linked condition causing infantile hypotonia, progressive spasticity, recurrent respiratory infection, and seizure. Myasthenia gravis is a spectrum of disorder characterized by easy fatigability of the muscle due to either an immune-mediated neuromuscular blockage or a disorder of the motor end plate. Transient neonatal myasthenia gravis occur due to transfer of maternal antibody from an affected mother to her fetus. Affected infant can demonstrate hypotonia, poor feeding, and even respiratory insufficiency, which is resolved without further sequelae as the abnormal antibody disappears. The juvenile form of myasthenia gravis is an acquired autoimmune disorder that occurs due to a presence of anti-acetylcholine receptor antibody It may begin in late infancy or childhood. Congenital myasthenia gravis syndrome are rare hereditary deficiency of motor end plate acetylcholinesterase production or function, including defect of its receptors. Ptosis and extraocular muscle weakness are the most common symptom. Rapid fatigue of muscle with the worsening symptom as the day progresses is characteristic. Diagnosis is confirmed by characteristic EMG finding. Anti-acetylcholine antibodies are only present in the immune-mediated version, not in the congenital form, and their presence is inconsistent in neonates born to mothers affected with myasthenia gravis. Rapid symptomatic improvement with a short-acting cholinesterase inhibitor, hydrofonium or progestin methylsulfate, is a clinical diagnostic test. It should be performed only in infant and children meeting specific criteria and only in a setting with the critical care support available. In congenital myotonic dystrophy, severe hypotonia, weakness, swallowing and sucking difficulty, congenital joint contracture, and sometimes respiratory insufficiency are evident at birth. These are usually infants born to mother with the symptomatic myotonic dystrophy. In childhood onset myotonic dystrophy, myotonia, a disturbance of muscle relaxation, may be the first symptom. It may precede the distal weakness by several years. Facial weakness is also characteristic. EMG findings are characteristic later in childhood, and genetic testing is available for definitive diagnosis. Diagnosis of the neonatal form, however, is usually based on clinical finding, often supported by a family history. Creatinine kinase is released by damage or degenerating muscle fiber. Electromyography measures the electric potential during various states of muscle contraction and may identify certain type of muscle disease. Muscle biopsy can distinguish between a neurogenic and myopathic process, and histochemical study will identify specific metabolic myopathies. More specialized molecular and biochemical testing may be necessary when metabolic disorders are progressive, encephalopathy are suggested. The evaluation for a metabolic disorder should include blood for complete blood count, electrolyte, pH, glucose, ammonia, lactate, acylcarnitine profile, and amino acid and urine for ketones, reducing substance, organic acid, and carnitine. Neurologic and or genetic consultation should be considered for specific recommendation for testing based on clinical suspicion. Systemic disorder may cause hypotonia due to disturbance of cerebral function. The onset may be acute or insidious, depending on the clinical picture. Laboratory study to assess serum electrolyte, renal and thyroid function, and to rule out infection should be considered. A lumbar puncture and cerebral spinal fluid evaluation may be necessary to rule out certain suspected infectious causes. If symptoms have been chronic or other neurologic abnormalities exist, a metabolic investigation should also be done. If a genetic disorder is suspected, chromosome study, including microarray, and consultation with the geneticist may be helpful. Cerebral palsy is a static encephalopathy, a non-progressive clinical disorder characterized by varying degree of mental and motor impairment. Rarely, hypotonia is prominent or persists. In most cases, hypotonia will progress to spasticity and dyskinetic movement. Commonly identified causes of cerebral palsy include perinatal hypoxia or asphyxia, congenital infection, and intracranial hemorrhage or trauma. Many causes are likely due to undetected perinatal events. In spinal muscular atrophies, degenerative loss of anterior horn cell in the spinal cord and brainstem motor neuron occurs. Progressive weakness develop in variant presenting in infant, juvenile variant of this disorder present beyond infancy. Diagnosis is by EMG, DNA probe, and muscle biopsy. Infantile botulism most commonly occur in infants between 2 weeks and 6 months of age. Source of the spore carrying the toxin of Clostridium botulinum may be honey, corn syrup, soil, or dust. Infants present with the descending flaccid paralysis, cranial nerve symptoms are typical noted first, manifesting as poor suck, feeble cry, drooling. Fever is characteristically absent. A recent history including poor feeding, constipation, weak cry and smile, hypotonia, ptosis, and mydriasis is common. Clinical diagnosis is key to early intervention. Diagnosis is confirmed by recovery of the organism or toxin from stool, blood, or food source. Older children can present with foodborne botulism due to ingestion of performed toxin in poorly canned food. Metabolic disorder, particularly inborn error of metabolism, usually appear in the neonatal period, although partial or incomplete error may not appear until later. A complaint of hypotonia combined with the history of recurrent bouts of lethargy, vomiting, acidosis, and other neurologic findings should prompt appropriate metabolic screen laboratory study. Some of the conditions to be considered include amino acid disorder, organic acidemia, urea cycle defect, fatty acid oxidation defect, adrenal insufficiency, and mitochondrial disorder. Pompe disease. Hypotonia in Pompe disease is the result of a glycogen storage in brain, spinal cord, and skeletal muscles. The presence of cardiomyopathy with abnormal electrocardiogram is highly suggestive of alpha-glucosidase deficiency. After establishing the diagnosis with the help of the enzyme analysis, patients should be offered enzyme replacement therapy. Developmental disorder of muscle are referred to as congenital myopathy. They are characterized by infantile hypotonia and weakness of variable severity and are generally non-progressive. Serum creatinine kinase value are typically normal. Diagnosis is usually by muscle biopsy. Metabolic myopathy include error of glycogen and lipid metabolism as well as disorder of mitochondrial function. Benign congenital hypotonia is a diagnosis of exclusion. It describes a non-progressive hypotonia, little or no developmental delay, generally good prognosis, a high family incidence is reported, all routine investigations are normal. If acute intracranial hemorrhage is suspected, like traumatic birth, depressed skull fracture, other head trauma, a head CT is the most appropriate urgent imaging study. Spinal cord disorder often present with the hyperreflexia, clonus, a positive Babinski sign, and defined sensory loss in the extremities. Hypotonia may be the prominent acute sign in infant. The diagnosis should be considered in infant with the hypotonia after a difficult delivery, particularly pre-delivery. Key point: differentiating between central and peripheral hypotonia is the first step. Targeted investigation will yield better result. Many of the diseases are inherited, hence genetic counseling is important. Neonatal hypotonia can be especially challenging to investigate. Thank you for your listening.